Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our first ACAP Vendor Education Series webinar of 2022, presented by Trapelo Health. Our presenter today is Clint Taylor, President at Trapelo Health, and he will be presenting the webinar, Adapting to the Precision Age of Cancer Care. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning, and the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Clint.
Thanks, Ron. Thank you all for joining our webinar today. We look forward to sharing some thoughts with you around adapting to the precision age of cancer care. Before I jump into that, though, I'd like to take just a moment to do a brief introduction and kind of set the stage for our discussion. And as Ron mentioned, we'll look forward to hopefully engaging with you in some questions at the end. I've had the opportunity to work in the field of oncology utilization management and decision support since about 2008. And I joined Trapelo in 2017. It wasn't called Trapelo at the time, but the company has today been in operation about 10 years. The focus when I joined the company was on helping oncologists better understand the lab test results that came back from molecular testing, and then align those with the interest of the payer to better understand what are the appropriate treatment options based on the most current clinical evidence. As we began to really look at this in 2017, we realized there are a lot of other challenges that go along with this, not just understanding the results, but even helping oncologists know what patients should be tested, what labs should be used, what markers should be tested. During this time, I was actually experiencing what many people do, which is the challenges when a loved one has cancer. My dad had cancer and was battling it at the time, and I found myself in a situation wondering, how can I help my own dad in this situation? I thought I knew a little bit about this stuff, but when you're faced with it and it's personal, I began to realize just how little I did know. And it was at that time that I realized that we have a really unique opportunity at Trapelo to really align the interest of providers, labs, and payers for in the specific interest of helping patients get on the right treatment therapy. So as we go through this today, hopefully you'll understand why I'm pretty passionate about this topic. I do think that this is something that's really needed today, and it is real to me. So I guess without taking any more time on an intro, let me just begin actually from a kind of a patient's perspective. We'll use this patient throughout our discussion today. This is Suzanne. She's a 58-year-old female who's been diagnosed with non-small cell lung cancer, stage 3. I hope you don't know somebody who's like Suzanne, but if you do, or if you've had a loved one, then you know this is a very scary diagnosis and one that causes everyone to say, we have to find the right treatment options. I think every cancer patient ultimately expects their oncologist to know precisely the best treatment path forward. For some reason, we simply think that that's the case. However, it's not always the case. In fact, the enormous growth in complexity and precision oncology has outpaced the ability of doctors to keep up, and that results in suboptimal treatment decisions. To give you an example, if we look at non-small cell lung cancer for Suzanne, the percentage of advanced non-small cell lung cancer patients who receive biomarker testing is still pretty low. In fact, fewer than 25% of non-small cell lung cancer patients receive testing for EGFR, ALK, ROS1, and BRAF, all biomarkers that can lead to some of the most efficacious and safe treatment options when that biomarker is present. Only 7% were tested for all 7 of these genes that are included in the clinical guidelines. Now, while this is data from late 2019, we know that from 2021, these numbers are still very, very similar in terms of patients who should be tested for these biomarkers that could lead to these really, really advantageous drugs, but they're not even being tested. But we also know that when doctors are using a clinical decision support tool to help them identify which patients should be tested, these markers change dramatically. And we start to see these biomarkers tested north of 94% of the time. So one of the things that we are striving to do, and we should be striving to do collectively as those of us who are on this call, is how do we help patients get tested for the right biomarkers at the right time? Even though the data is changing very rapidly, use of these kinds of tools can be helpful. I love this quote from Dr. Caroline Carney, the Chief Medical Officer at Magellan Health. The explosion of knowledge in this area, especially regarding genetic testing and the understanding of the genome as it relates to malignancies, is so rapidly changing that no single individual, no single medical director at a health plan or a health system can stay on top of it. And then we see this consistently. This is not just Caroline's view. I think most people agree that the information is simply changing too quickly to keep up with it. And it's changing from all directions. The precision medicine field is exploding. So as of recently, 84% of late-stage oncology drugs in the pipeline are for precision medicine and require molecular testing. And then who's performing these tests or seeing these patients? We know that 80% of patients today are treated by community oncologists, where they're seeing multiple types of patients every day with different types of conditions, where different biomarkers are relevant, different types of tests are appropriate. This enormous complexity creates a huge burden for these community oncologists. In a study published in ASCO, 69% of community oncologists either didn't know the answer or incorrectly matched the molecular alteration to the targeted therapy when they were looking at these molecular test results. One of the added complexities to this is where those of you on a call come into play, which is the traditional prior authorization processes. Because today so many payers still rely on kind of these traditional processes, it's creating a burden. This complexity has outpaced those processes as well. 58% of oncologists today cited payer pressures as the #1 challenge for their practice, with nearly 80% saying that prior authorization is the most troublesome of these pressures. And then finally, the cost of using precision medicine in the US will reach $100 billion this year. And we've been seeing a 12 to 15% growth. So we don't expect this to slow down as more and more biomarkers are appropriate and discovered with new therapies. When trying to get an idea of how rapidly this is growing, immunotherapy trials, as reflected here, gives us just an illustration of how rapidly it's changing. There were, in 2020, about 3,500 active PD-1, PD-L1 trials. Combination therapy trials have more than tripled between 2017 and 2020, and we saw the growth continue in 2021. And you can see that this shift from chemotherapy combinations to targeted approaches represents over 250 different targeted groups. In summary, this just shows that this is the pipeline. This is what's coming down the pike for doctors and for payers to try to sort out in a 48-hour turnaround time how quickly, it was roughly how quickly it takes to be able to then understand what's being requested and being able to decide whether these are appropriate treatment options or not. So this is driving some of the complexity. And as we work with different payers, and I've sat down with different payers across the country, many, to try to better understand the processes that are being used today to understand and to ultimately make a determination on these complex therapies. What I'm finding, and I think you'll probably agree, is that many people still many groups are still relying on a manual process. The current PA process with many organizations is complex, it's manual, it's time consuming, and it's error prone. And that's just before we get to making the determination of whether a treatment option is appropriate or not. Let's look at this flow chart for just a minute, and it represents the thousands and thousands of times that the doctors today make a targeted therapy decision. I told you that that the complexity is growing. Keep in mind, of the 550 genes with an established role in cancer, over 5 million associated aberrations have been cataloged. And so far, over 4,000 of these aberrations have been associated with a drug-based therapy. It's easy to understand why it's impossible to cognitively keep up with all of those, because they're also changing rapidly. A statistic I don't have a slide for is that we track this in real time, and we've seen over 200 policy changes, that is clinical guideline changes, within the last 12 months, just as it relates to the specific use of biomarkers for oncology. And that's too much for oncologists to keep up with and for payers to keep up with. Here's the way the process works today. I think you'll agree with it. Doctors typically rely on their own cognitive abilities to determine what test to order for a particular patient and which lab to use. And they'll often make this decision and then hand off this order or the instructions for the order to a staff person. The staff person will usually fill out a lab order form. 60% of the time, this is done on paper. And then they'll fax this to the lab. The lab then is going to go to work to try to get an approval for that lab test. By the way, NeoGenomics lab order form for oncology, just for oncology test, has over 250 checkboxes on it. So the opportunity for errors is pretty staggering when you think about this manual process. If the lab is able to get a prior authorization for the test and moves forward, the test will be performed, and a PDF lab report will be sent back to the doctor. And the doctor cognitively interprets the PDF lab report and decides what therapy to order. Remember, these lab reports often are up to 40 pages long. They're complex. They contain new discoveries and information that's changing very rapidly. Once the doctor interprets this, he or she will usually hand it off to a prior authorization department staff person who may either, depending on the prior authorization solution that's in place, they may either place a phone call and try to relay this information to someone on your team, or perhaps they'll try to enter it into a prior authorization system to get an approval or denial. Remember, this is highly technical, and the tiniest error can have a huge impact when it comes to using precision medicine. So here we have a $100,000 to $300,000 targeted therapy decision that's being approved or not based on data received in this prior authorization request. But the question is, was the right test ordered for the right patient? Were the results interpreted correctly and the information entered accurately by all parties throughout the entire process that is manual? This is why traditional prior authorization is such a challenge, because it can't confirm these parts of the process that are happening outside of the health plan. Now, hundreds of thousands of dollars and patient care is at stake and at risk based on this process. So what about the cost of this process? Let me walk through just a few of the steps that I think will help you better understand how big is the problem and how complex is it. The cost of precision medicine drugs today is growing, as you all know. I think in 2017, new drugs cost about, the new targeted therapy costs were about $80,000 Just a few years later, they doubled to 150,000. That's the number we're using here. The newest drugs are over 300,000 that came out last year. But let's look at this as an example of a health plan with 100,000 lives. So we can look at any cohort of 100,000 lives. The number of patients with advanced cancer who could be or should be tested, this is based on SEER data, we estimate to be about 720 patients. Some will just need testing for a few biomarkers and some more, depending on their condition. The percentage of patients tested who will likely have an indication for a targeted therapy is about 20%, meaning 1 out of 5 patients who are tested, we should find a targeted therapy option based on a biomarker that's present for that particular patient. Obviously, that means 4 out of 5 times we're not going to find a treatment option that's appropriate for that patient. So the number of patients likely to be eligible to receive a targeted therapy is about 140 patients in that 100,000 lives. So there's probably no smaller cohort of patients that create a greater cost exposure for your health plan. 144 patients, if we tested the 720 at $2,800 per test, and then if 144 of those were eligible to receive a targeted therapy, just drug only, and we had no adverse events, that cost would be about $23 million per year for those 144 patients and the testing that we did for the 720. So this is a big number, but it's not staying still either, because if we look at the current growth rates, then that 23 million grows to almost twice as much, 49 million at the end of 2024, based on IQVIA's estimates of growth rates for this particular, the use of targeted therapies. Some of the data we walked through, you might have noticed, is from 2019, 2020, some from 2021. So I thought it might be important for you to see the top 5 challenges as published in Precision Oncology News just this past month, where they were asked, what are the biggest challenges for oncologists at your institution or practice for implementing precision oncology? You might not be surprised to see the number one challenge. 30% of them said the number one challenge was to keep up with the data, to keep up with the guidelines. The field is moving too quickly. It's difficult to keep up with all of the biomarkers and the guidelines. And the second one, insurer denials or restrictive prior authorization. I was talking with a health plan, in fact, just before Christmas, who said that last year they denied 72% of the requests for NGS testing. Was that the right number? Admittedly, they said, we don't know. We don't know if we denied too few. We didn't know if we really denied too many, because the information simply is changing too rapidly. But 72% seems too high for any kind of denial and any kind of a prior auth process. One of the other areas has to do with access to clinical trials. The fact that we get test results back, but we don't know how to find or access clinical trials, no EMR integration, and no clinical decision support capabilities to help. So these are the biggest challenges for oncologists today, by their own admission. This was just published, as I mentioned, last month. So when we look at these challenges, as I mentioned earlier in the call, I'm very passionate about the idea that we can do better, that we should be able to do better. We should be able to help doctors and payers own this, I would say, important challenge of knowing who's the right patient that needs to be tested. Not all patients are good candidates for molecular testing based on their specific diagnosis and treatment history, and some patients who aren't tested actually should be. Both over-testing and under-testing drive unwarranted variability in care that lead to unnecessary cost. And remember, Suzanne often represents somebody that we know and deserves the opportunity to be tested appropriately, to be given the best opportunity to receive the treatment options that are most appropriate for her very specific treatment type or cancer type. Finding the right patients is the first step. Next is identifying the right biomarkers to test. And we mentioned that there are many, many biomarkers that are that may be appropriate for testing. We know that from the data I showed you earlier, patients with non-small cell lung cancer are not being tested for just the 7 biomarkers that are already known to be appropriate based on clinical guidelines. But then next you have to know what test to order, because not every test, just because it's a large panel and maybe an expensive one, doesn't necessarily mean it even includes all of the biomarkers that should be tested. What's more disheartening than not paying for a test when it should have been is to pay for the wrong test when it won't lead to an answer that was actually important to help maybe save this patient's life. And then finally, understanding those results enough to know which treatment options are appropriate based on the data that came back from the lab. These are the challenges, and this is why it's so difficult to simply say, let's identify at the end of the process whether a patient is being given the right therapy or not. If we can't answer the questions, should they have been tested? Did they get tested for the right markers? Was the right test performed? And now were the results interpreted properly? Usually when we're doing presentations at this point, every payer is saying, what's the value of getting this right? What are our real costs? We looked a little bit at the total cost of care for precision oncology, but what's happening today? Unfortunately, a lot of the data that is needed to really understand this is not able to be derived from claims data. So it's not easy to just run a report and find out how far off a particular payer may be in understanding how accurate this is. But we do have models that help you better understand how to look for these kinds of efficiencies and savings. And we break it down by each of these categories. So for example, what is the cost of getting the right patient tested? Let's use the same number of patients we used earlier, 100,000 covered lives. And there's the same numbers you saw earlier. Roughly 720 of them should be tested according to SEER data. The number of patients who should not be tested, but who are, in my assumption here, let's just say that 10% error rate occurred, meaning 10% of the time, a patient who should not be tested was actually tested. Now, if you have large academic medical centers in your network, then it's easy to believe that there may be 10% over testing. And if the average test was $2,800, then we would overtest 72 times, and that would cost about $200,000 in overtesting. There's also a challenge in the community, and it's a greater challenge in the community than in academic medical centers where patients are under-tested. And if the number of patients under-tested was 20% in the community, and if 20% of those actually could have found a better therapy by testing, which is, call it a 4% error rate, 20% of the 20%, and if the average cost of a less effective therapy was $50,000, then we drive another $1 million in avoidable cost just by getting the right patients tested. And we haven't even looked at getting the right test performed, just identifying the right patients. Usually when I'm talking to payers today, I'll ask, do you think that more than 4% of the time errors are being made that lead to inappropriate therapies regarding the use of precision oncology? And most of the time, the answer is a pretty easy, yeah. It's pretty easy to think that we're less than 94% effective across our network in finding the right patients who should be tested. Next, as I mentioned, is getting the biomarkers right. There's value in getting the biomarkers correct. For example, if the number of tests performed for the right patients were 720, as we decided earlier, but 10% of the time the wrong set of markers is selected, and 10% of that time it leads to a wrong treatment, that's a 1% error rate across the board. And again, the same 50,000, that would lead to $360,000 in avoidable cost just by getting the biomarkers correct and identified for each of the patients. Once the biomarkers are identified, we know which patients to test. We know which set of markers should be tested. Next is getting those orders performed by the right lab. not only do we want to identify labs that are in network, of course, for the payer, but more importantly, we want to identify whether that the test that's offered by that lab is the most optimal cost-effective test that includes all of the biomarkers identified previously. We also want to be sure that code stacking doesn't happen. That is where a lab bills you in various forms to optimize reimbursement when in fact it didn't add any value to the test that was performed. If we have a 15% error rate and the average cost of miscoding is $1,000, that would drive another $100,000 in avoidable costs just in making sure the right tests were ordered from the right lab. And then finally, the biggest part of this is in making sure that the right treatments were selected from the report as it was given back to the doctor. And you remember in the statistic I showed earlier in the 2019 study, 69% of the time doctors actually selected the wrong test, the wrong treatment from the lab report, which means that the burden of catching that error falls now on your prior authorization process. Were the right biomarkers tested? Did the results get interpreted properly? Not only were the right biomarkers identified, but are there specific variants within those biomarkers that might lead to a more efficacious or less efficacious treatment option? So getting this part right is super important. So if we look at the number of tests with a positive result, that was the 144 number, 20% of our patients who were tested. But if the percentage of the time that a misinterpretation of tests occurred in an overspend was 15% of the time, not 69%, but 15. And if the average cost was 80,000, and remember we identified the fact that today the average cost of these therapies is between 150 and 300,000. It's reasonable to suspect that if we got it wrong, we could drive at least $80,000 in overspend. Then that would lead to, and if we caught 20% of those with a really great prior auth process, then we would still experience about a 1.3, almost $1.4 million in avoidable cost by not being able to interpret the lab results properly. If we add those 4 steps together, you can see that we can identify easily in a very conservative way over $3 million in avoidable cost by getting this process right. Often when we're having these discussions and they're a little more dynamic, payers will tell me some of these costs are really underestimated because we know the kinds of costs that happen when a patient fails a chemotherapy regimen and now moves from the community directly to one of the more expensive academic medical centers. Lee Newcomer, who was the former chief medical officer at United Healthcare, served on our board for several years and once made the comment to me that they estimate that cost can sometimes quadruple when you move a patient out of the community and into a more expensive academic medical center. So the more effective we are in helping patients get the right treatment for precision oncology in the community, the more we drive out unnecessary costs and probably give that patient a better experience overall as well. So if we can drive out those costs, what's the impact for Suzanne? Well, first, it reduces the potential delays, matches test results with current published evidence to clearly identify the most appropriate treatment options for clinical trials for her, as well as appropriate treatment options. For the health plan, it provides a clear differentiation through quality precision medicine program. We would go beyond traditional prior authorization and address some of the friction that providers most so often complain about, which is their belief that if they're having trouble keeping up with the data, then the payer is likely having trouble keeping up with the data also. So this goes beyond traditional prior authorization. It enables better and more precise contracting with molecular testing labs. Today, payers are are basically relegated to negotiating lab tests based on a price for a test. But you have little opportunity to create a marketplace where those labs actually compete in real time based on specific biomarkers that should be tested. In other words, you're having to decide in real time whether a smaller, more cost-effective set of tests could be performed and still include all of the relevant biomarkers based on the most current and ever-changing published clinical literature. The other thing is that a program like this provides unprecedented data and monitoring for use in quality analytics. Today, if I said, how often are patients actually being under-tested? If you're requiring the use of claims data to answer that question, then you cannot answer the question because it doesn't exist in claims data. So there's no way today for a payer to know at this level whether the right patients were tested, whether the right biomarkers were identified and selected, whether they were included in the most efficacious lab order, and whether the results were interpreted appropriately based on all of the options that were presented. How in the world can payers looking forward into this new space of precision oncology imagine venturing into that without knowing the answers to those questions to know for sure that you're optimizing every patient's opportunity to get the right treatment options at the most the most efficacious and efficient cost? And finally, I just showed you how many clinical trials are exploding and how many new clinical trials are coming available. But the challenge today is understanding what those trials are they appropriate for a patient, and then identifying and getting those patients directed to those trials. Through programs like this, not only can you help the providers in your area identify those trials, but help patients understand better about those trials, because those may be the actual best treatment options and the most cost-effective treatment options for those patients. So we're about to wrap up the main part of this and open it up for questions. I was talking to Ron when we were preparing for this, and I said, Ron, am I supposed to hide the fact that this is stuff we do? And he laughed and said, no, it's obvious to everybody by now that you have some motive for doing this. We do. And our motive is simply that we've developed programs that oncologists subscribe to and payers can subscribe to, which creates real-time alignment so that you can know and doctors can know in real time which patients are candidates for the latest precision medicine advances, which biomarkers should be tested, which tests are more appropriate, which labs are not only preferred by the payer, but also could be preferred by the practice that can do and perform the test most cost effectively, which patients might be eligible for trials, and ultimately which tests and treatments can be granted a streamlined prior authorization because clinical decision support replaced the need for a more like a mother may I type of approach. And all of this while giving the payer unprecedented access to granular data that's literally impossible to get your hands on without a program like this. So we've also made available to you through this webinar a white paper that you guys can access. It's done along with clinicians and scientists that explain further why standardizing the use of precision medicine should be a top priority. It highlights some of the information we've just talked about. And then we have over 50 podcasts through our Precision Medicine podcast. We launched it. It's now the premier precision medicine podcast in the industry. You'll hear from, these are not selling podcasts at all. You'll hear from some of the leading thought leaders who are talking about this very important topic. Some are from the payer world. Some are from the pharma world. You'll talk to some who are clinicians who are grappling with this, with these challenges. But these are resources that you can look to if you want to dig a little bit deeper and understand better. What I have often said, look, we have a tsunami coming because this is growing faster and faster, and this is getting to a place where it's going to become really, really challenging, where today we might expect 20% of the patients to have a positive indication for a biomarker for this expensive therapies. Those numbers are going to grow, and we're already seeing those numbers grow. And then lastly, before I open it up for questions, is that if you'd like to see a demo of Trapelo, we certainly would be delighted to show you this. We work with payers across the country. We launched Trapelo in 2019. So don't expect us to be able to say, look, I have 100 payers who have been doing this for a long time. We are innovating, and we are making some great changes in the process. But we do have some great examples and some great use cases of groups who have moved forward with this and the experience that they're having. We'd be happy to set up a time for you to see a demonstration of Trapelo if that's of interest to you. So I'm going to pause and take a drink of water and give you guys a chance to ask any questions you might have about anything we've talked about or anything we haven't.
Great. Thanks, Clint. Hi, everyone. I'm Karen Cushman. I am on the Trapelo team with Clint and here to be the moderator today for our Q&A. We have quite a few questions already, so we'll just dive right in here. So Clint, one of the first questions is, how do you build a financial savings model for a clinical decision support tool like Trapelo, since health plans can't determine the extent of under-testing, over-testing, or just incorrect testing?
Yeah, this is obviously, I can understand why this is the first question, Karen, because this is probably always the first question. And it's one of the biggest challenges that we face, quite honestly, because as a payer, we know how important it is for you to understand a baseline of what's a current baseline of opportunity to drive savings. The very first thing we often do is we will look at what information we can get to. And there are data points that we can get to. We can certainly understand how often precision oncology is being used in your network. We know where the big users are through data that you'll work with us to look at. But ultimately, you're going to have to make a transition to something like this if you're going to ever have the level of granularity that you are going to need to go forward. So what we've done with other payers is develop very limited type of pilot programs where we can identify certain practices within your network. We don't have to roll this out to the entire network. We don't even have to roll it out to entire populations. We can start with small groups. We can start with practices, and we do collaborative pilots with them. And we're doing this across the country. We would just work with you to identify groups, and then we would begin to establish baselines based on that. And then we use real-time transparency, which I think you'll find to be very, very compelling. Rather than looking back 90 days or so at claims data to understand what's happening, you actually see real-time dashboards. How many patients were ordered? How many patients received a molecular test order yesterday? How many reports came in to doctors and they reviewed them within the last 24 hours. I mean, these are real-time reports that allow you to see this in a much more dynamic and real-time way. And so, and then we use the models similar to the ones I showed you here in the presentation to establish those baselines and begin to establish goals for moving forward on how to construct the savings models.
Great, thanks, Clint. A couple more here. How do you approach an implementation when there needs to be a collaboration between 3 separate stakeholders, the payer, the provider, and the lab?
Yeah, that's a great question. When we started Trapelo, I had previously driven companies that provided URUM, and we go directly to the payer and we put into a program, and then the payer rolls the program out and it becomes mandatory, and every doctor just has to go along with the program. With Trapelo, we approached it differently. We actually went to the providers first because doctors today are so aware of the fact that this data is changing so quickly. We actually approach the providers, and providers can license our decision support resources, and then they will often be the first to help champion this to payers. And of course, as a payer, you probably would appreciate the fact that when providers come to the table saying, we have a solution that we believe is mutually beneficial for everyone, it's win-win for everyone, it makes those collaborations much easier. So usually what happens is we'll have a discussion like we're having with you today. As a payer, you might help us identify some of the key practices in your network. We'll approach those practices. We'll share with them how Trapelo works and invite them to be a part of a pilot. We'll streamline the prior authorization process for them. We'll increase transparency. With the promise that we'll actually reduce the denials on testing, but at the same time, not taking away any of the scrutiny or important transparency that payers need. And this is usually a really, really well-received value proposition to providers, and it usually kicks off a really good and strong, healthy collaboration.
So probably one of our second or third most popular questions is around prior auth, and digging in a little deeper there, Clint. How does Trapelo differ from a traditional Mother May I prior auth approach?
Well, I think the biggest way to think about it is that if you knew that the doctor was being presented with options that were already consistent with your policy and with the latest published clinical evidence, and you could see them making those right decisions in real time, you would feel comfortable not having them place a call to you for every one of them. So for example, the biggest difference is that out of 100 cases, if 90% of the time the doctors would pick the right thing, and then 10% of the time when they want to make a request that seems to be inconsistent with policy and or guidelines, you'd now be dealing with 10 prior auth requests and not 100. And that's really where we focus, and that's the biggest paradigm shift in this. And of course, as a payer, you want to know that the right tests are being ordered for the right patients and that the results are interpreted accurately. And if you can see that in real time based on the literature and compliance with your policy, then getting rid of 100 times when they're going to ask you for this can be a really big plus. We had another really important board member who served with us for a couple of years, who was a former CEO of a large Blues plan. And he was especially important champion of ours because he recognized how inefficient it is for doctors to have to ask 100 times about something when the ultimate denial rate might be really, really low, relatively low, 5% or 2%. And so he was a big champion in helping us as we have been driving toward this, because he said, look, I really just want to know that the right things were done. And if the wrong things are being done, I want to deal with those by exception. And I think that's really the biggest difference in more of the traditional Mother May I approaches, which is they're going to call and ask for permission each time. If we can avoid that, we create a more efficient, more streamlined process for achieving a much better outcome.
Great. So Tim Wilson, he is asking a great question around the complexity and the number of guidelines that physicians need to keep up with. And we know this pretty well. If Janine was here, I bet the number would be even higher. Janine Morales is our Chief Scientific Officer. So the question is, how many different precision medicine guidelines do physicians need to stay on top of to ensure they are knowledgeable about what specific tests are appropriate and recommended for a given oncology disease state?
You know, that's a great question. I don't have a specific number, but you may have noticed, if I can just back up a few slides, you may have noticed I referenced this particular number. Now, keep in mind, if I'm a community oncologist, I'm not just seeing one type of cancer patient, whereas if I'm at City of Hope, maybe I'm only seeing lung cancer patients. Maybe I'm just seeing stage 4 non-small cell lung cancer patients. But if I'm in the community, I'm seeing all kinds of patients. So remember, of the 550 genes with an established role in cancer, so there's over 550 genes, because I know that this information is starting to be dated. I don't know exactly how many it is, over 550, but there are over 5 million associated aberrations that have been cataloged, and over 4,000 aberrations have been associated with a drug-based therapy. Remember, this is just for precision medicine. So this does not even include all of those immunotherapy clinical trials options that are exploding. It's mind-boggling to even fathom how many there are for treatment options for doctors to consider. But remember, in this chart, if the doctor never begins by ordering a molecular test, then those options are just limited to chemotherapy, radiation treatment options. And not to say that those aren't always the wrong option. Sometimes one of those is the best option. But what's missing is what is often the best option for patients, which are those very, very specific targeted therapies that are very specific to that patient's tumor type and the characteristics of that patient's specific tumor disease.
Great, thanks, Clint. I think that's about all of our questions. Referencing back to Janine, you know, a while ago, we were doing some calculations in the updates in the Trapelo knowledge base, and there was a moment in time where we had said, you know, there has already been 200 in the year of 2021, and so it's just coming at us faster and faster.
I think, Karen, yeah. What's interesting on that, and I think I may have referenced that a little bit earlier, and I don't know if I explained it very well, but those 200 actually led to guideline changes. Those were very specific. They resulted in guideline changes, and we're looking at NCCN, we're looking at ASCO, ASH, where all of the main publishing bodies that put out this kind of literature. Those were changes that resulted in clinical and true guideline changes. And I think that was as of July of last year. So halfway through the year, we had 200 of those. If you ask Janine, she would tell you that we've probably made over 1,000 modifications to our knowledge base based on new information that's come out. Not all of them lead to a specific guideline change yet, but many of them are leading in that direction. So it is an enormous amount of information. It is changing very rapidly, and the growth of that is changing as well.
Awesome. All right, we're about 10 minutes shy of the top of the hour. So I think
I gave everybody 10 minutes back.
We did.
Well, I want to thank everyone for attending, and thank you, Ron, for hosting and allowing us the opportunity to share this information with your members.
Well, you're welcome. And we want to thank you for a very informative webinar today. I'd also like to thank all the attendees for taking time out of their day to join us. With that, I'd like to remind them that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks a lot and have a great day. Stay safe.
Thank you, Ron.